Assalamualaikum warahmatullahi wabarakatuh. I am Abdullah Syauqi bin Kuseri, a student in Master in Public Health University Malaysia Sarawak year 2022 and 2023. For assignment 2 in the Epidemiology course, I have to conduct a seminar presentation regarding a mother topic on certain concept of epidemiology. The topic is related measurement used in screening tests, which include invalidity and reliability tests. My topic where we will be looking on calculation of sensitivity and specificity, how they are calculated, and two related measurement, which is positive and negative predictive values. And we also will be looking on Kappa agreement calculation, which used to assess inter-observer reliability. Sensitivity and specificity are measures that can be used to determine how good a test is at correctly identifying the presence or absence of disease. Take a closer look. Let's use a table of the outcome of the test and disease status to learn about some of the terms that are used. There are people with a disease and those without the disease. When we do a test on someone, it can be either positive or negative. If the test is positive, it should mean that the person has the disease. This is called a true positive. It correctly identifies a person with the disease. On the other hand, when we do a test on someone, it can be either positive or negative. If a test is negative, it should mean that the person does not have the disease. This is called a true negative. It correctly identifies a person without the disease. Okay, however, because tests are not always perfect, a test can be positive even though the person does not have the disease. This is called a false positive. This is not ideal because it could lead to further testing on or treatment that is not necessary for the patient, negative psychological impacts, and may come with an economic cost or added risk to the patient. On the other hand, a test can sometimes be negative even though the person has the disease. This is called a false negative. Again, this is not ideal because the test has not picked up the person despite them having the disease. This may lead to delays in diagnosing and treatment, which could lead to a negative health outcome. It also may lead to false sense of security and the continuation of risky behavior that may worsen the disease. Missing a diagnosis may also have legal consequences. We can calculate the sensitivity and specificity of the test. These are indicators of how good a test is and guides us on how to determine the appropriateness of a test and interpret its outcome. Sensitivity is the proportion of people with the disease who tested positive for it. A high sensitivity means that the proportion of true positive is high and the proportion of false negative is low. Specificity, on the other hand, is the proportion of people without the disease who tested negative for it. A high specificity means that the proportion of true negative is high and the proportion of false positive is low. Specificity is also an indicator of how good a test is and guides us on how to determine the appropriateness of test and interpret its outcome. Through an example, let's say we have a group of 600 people. Let's assume that 100 people have the disease and 500 people don't. First, we will focus on the 100 people who have the disease. Let's say that we do a test on people with the disease. If the test is positive only in 95 people, which is 95 true positive cases, this leaves us with 5 people that are false negative. Therefore, in this example, the sensitivity of the test is 0.95 or 95%. Now, let's do the test on the 500 people without the disease. But let's assume that the test was negative in only 450 people, that these are true negatives. This would then mean that in 50 people without the disease, the test was positive. These are false positive. So in this example, the specificity of the test is 0.9 or 90%. Tests with high sensitivity are good for screening tests because the proportion of false negative is low. On the other hand, tests with high specificity are good for confirmatory tests because the proportion of false positive is low. The perfect test will have sensitivity of 100% and specificity of 100%. The closer a test sensitivity and specificity to 100%, the better the test is in confirming or excluding the disease. Okay, finally, let's have a quick look at two related measurements in validity. First one is positive predictive values and the second one is negative predictive values. It uses the same information but looks at it from a testing point of view. Let's use the same values that we are using in our previous example for more understanding. Okay, there are 145 people who tested positive and 455 people who tested negative. The positive predictive value is the proportion of people with a positive test who actually have the disease. In this example, the positive predictive value is 65.5%. Okay, for the second one is negative predictive value. The negative predictive value is the proportion of people with a negative test who do not have the disease. For this example, 450 divided by 455, in this case, the negative predictive value is 0.989 or 98.9%. Positive and negative predictive values depend on the prevalence of disease, or in other words, how much the disease there is in the population. In general, an increase in disease prevalence is associated with an increase in positive predictive values and decrease in negative predictive values. Precision or inter-rater reliability is often reported as a Kappa statistic. The Kappa value can give us a quantitative measure of the agreement in any situation in which two or more independent observers are evaluating the same thing. Kappa agreement is calculated by percentage of observed agreement minus by percentage of expected agreement by chance divided by 100 minus percentage of expected agreement by chance. For example, imagine two doctors are examining jaundice clinically in 100 patients. Dr. A and Dr. B agree that 70 patients have clinical jaundice and 10 cases do not have clinical jaundice. They would have 80% of agreement. However, if both of them randomly evaluate the patient, they would sometimes agree just by chance. The Kappa value take this chance into account. Expected agreement is calculated by multiplying the positive answers of Dr. A with the positive answer of Dr. B right here. So we have 75 through 100 and 85 through 100, and we multiply those two values with each other. Then we add them to the negative answer of Dr. A, which is 25, and the negative answer of Dr. B, 15, which are also divided by 100 and multiplied with the 100, and then we end up with 67.5% of expected agreement just by chance. Kappa agreement is calculated by percentage of observed agreement, 80%, minus percentage of expected agreement just by chance, 67.5%, divided by 100 minus percentage of expected agreement by chance, 67.5%. So we have a Kappa agreement of 0.34. So what does the Kappa value of 0.34 means? According to commonly used scale, this would mean that the two doctors have a poor agreement on which patients are clinically jaundiced and which ones are not. Noted that the Kappa value of 0 or less means no agreement at all, while a value of 1 means perfect agreement. Alright, this was my video on related measurements in the screening test. I hope this explanation was clear for you. Thank you very much.